Urinary tract infections in children. Dr. Afif El-Kafash, Specialist Registrar in Pediatrics. Introduction. Urinary tract infections, UTI, are a common and important clinical problem in childhood. Upper urinary tract infections, EA, acute pyelonephritis, may lead to renal scarring, hypertension, and end-stage renal disease. Difficult on clinical grounds to distinguish cystitis from pyelonephritis, particularly in young children, those younger than 2 years. Prevalence. The overall prevalence of UTI is approximately 7% in febrile infants. White children have a 2 to 4-fold higher prevalence of UTI than do black children. Girls have a 2 to 4-fold higher prevalence of UTI than do circumcised boys. White girls with a temperature of greater than or equal to 39 superscript OC have a UTI prevalence of 16%. Prevalence. Older children are more likely to present with urinary symptoms in association with a UTI than younger children. Microbiology. Escherichia coli is the most common bacterial cause of UTI, 80%. Other gram-negative bacterial pathogens include Klebsiella, Proteus, Enterobacter, and Citrobacter. Gram-positive bacterial pathogens include Staphylococcus saprophyticus, Enterococcus, and, rarely, Staphylococcus aureus. Microbiology. Viruses, e.g., adenovirus, enteroviruses, and fungi, e.g., Candida spp, Aspergillus spp, Cryptococcus neoformans, endemic mycoses, are less common causes of UTI in children. Viral UTI are usually limited to the lower urinary tract. Risk factors for fungal UTI include immunosuppression and long-term use of broad-spectrum antibiotic therapy, and indwelling urinary catheter. Pathogenesis, the result of ascending infection. Colonization of the periurethral area by uropathogenic enteric pathogens is the first step in the development of a UTI. In E. coli, pili, hair-like appendages on the cell surface aid in attaching to epithelium. In the kidney, the bacterial inoculum generates an intense inflammatory response, which may ultimately lead to renal scarring. Risk factors: boys less than 1, girls less than 4, short urethra. Uncircumcised boys. White children x4, greater than black children. Family history of UTI, genetic factors. Urinary obstruction, PUF, UPJ, myelomeningocele, neurogenic bladder. Vesicoureteral reflux, VUR. Sexual activity. Bladder catheterization. The vesicoureteral reflux, VUR, is the retrograde passage of urine from the bladder into the upper urinary tract. It is the most common urologic anomaly in children, occurring in approximately 1% of newborns, and as high as 30 to 45% of young children with UTI. Pathogenesis. Primary VUR, the most common form of reflux, is due to incompetent or inadequate closure of the ureterovesical junction, UVJ. Secondary VUR is a result of abnormally high pressure in the bladder that results in failure of the closure of the UVJ during bladder contraction. Secondary VUR is often associated with anatomic, e.g., posterior urethral valves, or functional bladder obstruction. Grading. Grade I, reflux only fills the ureter without dilation. Grade II, reflux fills the ureter and the collecting system without dilation. Grade III, reflux fills and mildly dilates the ureter and the collecting system with mild blunting of the calyces. Grade IV, reflux fills and grossly dilates the ureter and the collecting system with blunting of the calyces. Some tortuosity of the ureter is also present. Grade V, massive reflux grossly dilates the collecting system. All the calyces are blunted with a loss of papillary impression, and intrarenal reflux may be present. There is significant ureteral dilation and tortuosity. Grading. Mild, moderate, severe. Risk factors for renal scarring. Recurrent febrile UTI. Delay in treatment of acute infection. Dysfunctional elimination. Obstructive malformations. The clinical presentation. In young children, less than 2 years, fever, vomiting, poor feeding, abdominal tenderness, irritability. Older children, fever, urinary symptoms, dysuria, urgency, frequency, incontinence, macroscopic hematuria, and abdominal pain. The constellation of fever, chills, and flank pain is suggestive of pyelonephritis in older children. History. Chronic urinary symptoms, incontinence, lack of proper stream, frequency, urgency, withholding maneuvers. Chronic constipation. Previous UT. Vesicoureteral reflux, VUR. Previous undiagnosed febrile illnesses. Family history of frequent UT, VA, and other genitourinary abnormalities. Antenatally diagnosed renal abnormality. Elevated blood pressure. Poor growth. Clinical examination documentation of blood pressure and temperature. Growth parameters. Abdominal examination for tenderness or mass. Assessment of suprapubic and costovertebral tenderness. Examination of the external genitalia for anatomic abnormalities, e.g., phimosis or labial adhesions, and signs of vulvovaginitis, vaginal foreign body, sexually transmitted diseases, STDs. Evaluation of the lower back for signs of occult myelodysplasia, e.g., midline pigmentation, lipoma, vascular lesion, sinus, tuft of hair, which may be associated with a neurogenic bladder. Evaluation for other sources of fever. Urinalysis. Laboratory investigations. Urinalysis, clean catch or suprapubic aspirate. WCC, RCC, nitrites, E. coli, sensitivity of 80%. Urine microscopy. Urine culture. FBC, UE, SP. Blood culture. Lumbar puncture in a febrile child less than 3 months. Management. The goals of treatment. Elimination of infection and prevention of urosepsis. Prevention of recurrence and long-term complications including hypertension, renal scarring, and impaired renal growth and function. Relief of acute symptoms, e.g., fever, dysuria, frequency. Hospitalization age less than 3 months. Clinical urosepsis or potential bacteremia. Immunocompromised patient. Vomiting or inability to tolerate oral medication. Lack of adequate outpatient follow-up, e.g., no telephone, live far from hospital, etc. Failure to respond to outpatient therapy. Antibiotics amoxicillin, or coamoxiclav, gentamicin sfotaxime. Children younger than 2 years and children with febrile or recurrent UT are usually treated for 10 days. Duration of therapy. Children younger than 2 years and children with febrile or recurrent UT are usually treated for 10 days. TMPSMX or nitrofurantoin may be initiated after completion of treatment and continued until the results of the imaging tests are available. Children older than 2 years who are afebrile, and without abnormalities of the urinary tract or previous episodes of UT are usually treated for 5 to 7 days. Such children have a low risk of recurrence or complications. Imaging studies. Routine imaging, Russ and McCug, 4. Girls younger than 3 years of age with a first UT, children older than 3 years are more reliably able to verbalize urinary symptoms. Boys of any age with a first UT. Children of any age with a febrile UT. Children with a recurrent UT, if they have not been imaged previously. First UT in a child of any age with a family history of renal disease, abnormal voiding pattern, poor growth, hypertension. DMSA scan. Renal scintigraphy using dimmer captures succinic acid, DMSA, can be used to detect acute pyelonephritis and renal scarring in the acute and chronic settings, respectively. DMSA is injected intravenously, and uptake by the kidney is measured 2 to 4 hours later. Areas of decreased uptake represent pyelonephritis or scarring. Scintigraphy at the time of an acute UT provides information about the extent of renal parenchymal involvement. Most, greater than 80%, children with moderate to severe VA, grade 3 or higher, will have a positive DMSA scan. Some have advocated DMSA be used instead of a MCUG to identify children at higher risk for renal scarring. MCUG. DMSA